davetleri için teşekkür ederim. I would like to invite Dr. Hari. He has two speeches. The first one is about myelofibrosis.
I will try to get us back on time too. So first one is another a rare disease, myeloproliferative neoplasms, and we have there is a lot of change happening in the world of myeloproliferative neoplasms, especially since JAK2 inhibitors have come into the market. Right now we only have one approved one, ruxolitinib or Jakafi, but there are others coming too. And these have changed the way we approach this disease. In fact, the activity for transplant has gone up and the outcomes are actually very good in these days. Let me show you how. So obviously, why do we need to transplant some of these people? Because that's still the only way of eliminating the malignant clone. And there has been major historic barriers to transplant for myeloproliferative neoplasms in the past. So there is a risk of non-engraftment. High treatment-related mortality. If you look at studies from before about 2005, the treatment-related mortality in those studies was 30 to 45%. So it was relatively younger and fitter patients who got it, and the majority of patients who are in their 60s when they get diagnosed with myeloproliferative neoplasms, there was no willingness to take them on to an allo transplant and cure them. So I'm going to talk about a patient, and you can tell me how many people will transplant that patient. You're all allo transplanters. We're very bold transplanters from the cases that we heard yesterday. So let's see. A 47-year-old man who in March 2000 has platelets of 865,000, and I think he came to see Chris Bredesen while he was at the So he was diagnosed with ET after a bone marrow and was treated with aspirin alone. So, and Chris actually told him not to get transplanted at that point, which was the right thing, obviously. 2008, he was found to be JAK2 mutation positive, and then he had progressive increase in spleen size from that time onwards. And when I saw him, 16 centimeters below the costal margin, so it's pretty big spleen.
Just interject. I left in 2010. So I didn't let him get that bad.
So he sees me in 2012. His hemoglobin is 9. He's come down quite dramatically by that point. His white blood count is 18,000. Platelets are 216. No blasts in the peripheral blood. And he started requiring transfusions around December of 2012. So it's 12 years since diagnosis, and he's now become fibrotic. So he has post-ET myelofibrosis according to the international criteria. He had grade 2 out of 3 fibrosis, and his cytogenetics is deployed. So at this point, he's 59 years old, and we have a question. Should we transplant this patient or not? He's JAK2 mutation positive. His donor evaluation shows he has a matched sibling donor. He has a good performance score other than the myelofibrosis itself. He has infrequent night sweats but no other significant symptoms. He has abdominal discomfort, and at this point actually he was starting to lose weight because he cannot eat much. His belly is getting full. So question is, what would you recommend? Wait and watch, Hydrea, JAK inhibition. So the only available agent is ruxolitinib at this time. Reserve transplant after you do this and wait for JAK inhibitor therapy to fail, or do a transplant while he is responding to JAK1/2 inhibitor, or just go and transplant, don't use JAK inhibition. So let's see, how many people would do reserve transplant at failure of JAK inhibitor therapy? Korgun. He's no longer Turkish. He's become soft. Plan transplant. So put him on JAK inhibition, plan a transplant while he's responding. I think that's what I would do too. And upfront transplant, I think. Anyone would just without JAK inhibition?
Well, he's not transfusion dependent, right?
Well, you can shrink his spleen.
Well, you can shrink his spleen.
So that's actually the question.
I mean, he's not transfusion dependent. He's not really having bad symptoms. Why would you transplant?
He's losing weight, big spleen. It's
So
not going to get any better.
But I think that's because of the spleen.
So thank you for that question. That's a central question. So that's the real question. So when do you transplant somebody with myelofibrosis? So one day before they actually are desperate for a transplant. So if you wait till they desperately need a transplant, it's a little too late. So we'll talk about that. That is the real, that is what we're trying to answer here. So that's true. So, if you look at the options available to patients with myelofibrosis, conventional therapies are, treatment for spleen, hydria, splenectomy, low-dose radiation, transfusion support, and for anemia, transfusion support, EPO, corticosteroids, androgen prednisone, IMiDs. They've all tried all these things. These are conventional therapies. And then the only approved drug is actually a JAK2 inhibitor, as we know. And there's a lot of drugs that are in development. There's actually a ton of drugs in development. Imetelstat, which is the telomerase inhibitor, and new HDAC inhibitors, crizotinib, other JAK inhibitors. And then there's a whole variety of JAK inhibitors, fedratinib, momelotinib, gilteritinib, which is the one that we are trying for GVHD. And some of them have already tried and failed. Pacritinib was in trials for post-Jakafi failure patients, and the trial got closed because of excess mortality. However, they actually have a signal for JAK failed patients where this drug is actually improving survival. And one of the other things that we have seen is when this study closed and some of the other studies closed, patients who were on the drug were asked to stop drug because the study closed and the FDA said stop this trial. The moment they stopped the drug, we had at least 2 or 3 admissions of patients who had a rapidly proliferating spleen, a flare reaction. So as many of you have known that, and which a French transplant study showed too. So there are options, but then there is only one option for cure still, stem cell transplant. So question is who, when, and balancing the too well to risk it, which is what Dr. Akpak says, or too ill to do it safely. So you wait too long, your patient is too ill to do it safely. If you do it too early, the patient is too well to risk it. So how do you do it? And the final important thing is how to integrate JAK inhibitors. Do you do transplants before they get exposed to JAK inhibition at all, while they are responding to the JAK inhibition, or use JAK inhibition to the maximum benefit, and then they fail that, there's no other option left to go to transplant. So this is the 3 options. And then some special details about conditioning, how to deal with some special risks, spleen, liver, portal system, we'll talk about those in. So again, who to send for a consult? So our only risk stratification score is the DIPSS score, or DIP score. So we have low risk, intermediate 1 risk, which are survivals of around 10 years or more. Intermediate 2, survival immediately drops 50% to about 5 years, and high risk, it's about 2.3 years. So it's really high risk. I think most people wouldn't hesitate because the survival is less than 3 years or 2.5 years. And for those patients, early referral, we still get them. And if they're symptomatic, you can use JAK inhibition. Clinical trial if they've already failed a JAK inhibitor. For intermediate risk, there is some confusion, doubt, because they have at least 5 years. And then for intermediate 1 and low risk, most physicians would hesitate.
What did you put your patient into the risk category?
Intermediate 2. Splenomegaly, some
white blood cells were high.
but 18, exactly, yeah. So the question is, are these useful to the transplant physician? They are for patients who did not, around 1,000 patients were used to develop the system, but very few of them, almost none of them got transplant. So we don't even know if this is useful to us. Most of these scoring systems ignore the leukemic risk, organ status, and the timing question, how and when to do the transplant. These are some of the phase 2 data that exist for transplant in myelofibrosis. So you can see that the survival, overall survival is all over the place. These are all small studies, so we should just ignore this. These are all anecdotes. We have no data to guide us. So next question. So this is a 59, this man, our patient, is match SIP donor. We have decided that we're going to transplant him. He's doing well on Jakafi. So what would you do conditioning regimen wise? Myeloablative, reduced intensity, if so which regimen? Flu-Bu 4, which is a myeloablative regimen, Flu-Bu 2, which is a reduced intensity regimen, fludarabine melphalan, Bucy, Cy-TBI. So how many people for Cy-TBI? No, nobody. Bucy? Nobody. Flu-Mel? There is at least a percentage of people. Flu-Bu, reduced intensity, quite a few people, yes. Flu-Bu, myeloablative? actually so good. So I think Flu-Bu-Ric is a winner here, Flu-Bu 2. Flu-Mel is the second one. So I will show you data for both. So now what's happening in the US. I have data from the CIBMTR as usual. So before the Jakafi era, JAK2 inhibition was approved around here. Before that, we were doing about 100 transplants a year. This is 2-year data. And now we doubled it to about 200, and it's actually gone up even higher after 2013. The regimens, again, they were reduced intensity and myeloablative. Myeloablative is a little bit more. Now reduced intensity is picking up, mainly because people are getting JAK inhibition, feeling better, performance status is improving, and older patients are getting transplanted. And again, as you can see, the age of the patients. So if you go back to 2004, pre-Jakafi, almost nobody above the age of 65. Now it's actually equally distributed. It's about 25% above the age of 65. So older patients are getting transplanted, people are doing more transplants, and that, I think the biggest change is people are getting JAK inhibition, responding, and coming to transplant. If you look at survival, we have survival, so that, the latest years we don't have 3-year overall survival, but I put that in. So almost 70% of our patients are at 1 year and doing well, and the 3-year survival is about 50%. So if you think about it, for patients with high risk, clearly this is a better option. Patients with intermediate 2, we still have to think about so these data show that, for high risk, clearly this is intermediate 2 is the median survival is 4.8 years. Intermediate 1, who are the patients who would take? So there are other things we need to consider in those patients. Predominantly, the risk of them getting leukemia. So there are 2 ways of dying from myelofibrosis: a bone marrow failure way of death, which is transfusion dependence and then death, or transformation to leukemia. So we need to have stratifying technology to find out who are these patients who have high risk that will predict for early leukemia. And then patients who are transfusion dependent, just as Dr. Akpek said, if they are anemic and they are requiring a lot of transfusions, yes. And then blasts in peripheral blood, which actually does go into that scoring system. So if you look at transplant versus non-transplant according to the DIP score in younger patients. So if you have low risk patients, this is a retrospective study that tried to predict DIP score with transplant. So low risk patients who get transplanted versus no transplanted, that non-transplant wins. Intermediate 1, it's about the same. Intermediate 2, there's a small victory for transplant, but look at it, it doesn't look so great. High risk, again, transplant. So these two are this is a retrospective study, and there are problems with this study, obviously. So this was presented at ASBMT.
How could you really make the patient with the peripheral blasts or transfusion dependent as a, intermediate 1?
Yes,
I mean,
yeah, that's.
It just doesn't make sense to me, though.
There are people though
who have no constitutional symptoms, 1 or 2%, 1% blasts, no constitutional symptoms. They will be intermediate 1.
Yeah.
And young.
And young, yes.
So we've had that with thrombocytopenia.
So we've had that, where in intermediate 1, when you have no platelets.
Yep.
And it's like, well, you're going to die of no platelets.
Exactly, and they're going to be platelet refractory. Their spleen, is eating up all the platelets you give them, and you end up transplanting them. So high risk of leukemic transformation is something that is coming more and more into the picture. So for example, isochromosome 17q, trisomy 8, monosomal karyotype, complex karyotype, and if you have access to next-gen sequencing, things like ASXL mutation. So if you have high risk of leukemic transformation, i.e. ASXL1, EZH2, SRSF2, isocitrate dehydration. So a combination of these can predict who is going to get more so high molecular risk patients. Based on that, so the risk of leukemic transformation is predicted here. Again, you should do at least 3 mutation analysis in your patients: calreticulin, MPL, and JAK2. And if you're triple negative, your risk of leukemic transformation is pretty high. If you have the number of mutations is another way of predicting it. And if you have 3 to 4 mutations, your risk of leukemic transformation keeps on going up. This is after a landmark at 5 years. So these are some of the predictors, factors that we typically don't look at. But in a young patient, if somebody presents to you at age 45, they are triple negative and ASXL1 positive, at this time I really don't have any hesitation recommending an allotransplant to them, because I don't think that patient is going to live out a normal lifespan with JAK inhibition or any other therapy we have. Severe thrombocytopenia is another clinical predictor of high-risk leukemic transformation. So again, there is minimal data on use of JAK inhibition in these patients because JAK inhibition does not improve the thrombocytopenia immediately. You put them on full dose JAK inhibition, their thrombocytes drop even more. What sort of donors do we have data on? Again, as you can see, in the olden days or in the 1 decade ago, sibling donors were the only people who were getting transplanted. That has almost completely changed now, and there are some haplos coming up too now. So selection of upfront therapy. So these are the latest CIBMTR data that got published on for upfront transplant. Again, these are from about a period before about 2012. And as you can see, if you have a sibling donor or a well-matched unrelated donor, you have long-term survival, about 120 months out. You have 50% of patients surviving. You have 10-year survivors who are cured. Next question, should there be an upper age limit? So again, as you can see, the transplant age group has been going up and up. And in the US, we now have the system of paying for patients above the age of 65 is something called Medicare. And Medicare just approved us doing all allotransplants for myelofibrosis if they join to the registry reporting for CIBMTR. So it's kind of like what we do for MDS. So Medicare just approved that for both myeloma allotransplants and myelofibrosis allotransplants. So older patients are now having access to it. And our president is almost 70 years old, actually more than 70. He's the oldest president ever when they took office. So I think we are going to transplant a lot of 70-year-olds now. So
Hopefully some die of tear.
hoping to cause some tear up. So so when we tested the audience here, I think equal numbers said Flu-Mel and Flu-Bu, reduced intensity. That is actually the most popular way of doing it. Flu-Bu ablatives still around about 16%. I do it if patient is less than 60 years old. I always do Flu-Bu ablative. I'll show you why. Here is the overall survival by conditioning intensity. There's really no change. So in myelofibrosis, you don't need a lot of conditioning. So these are some of the data for MAC versus RIC in myelofibrosis. Again, these are registry data or retrospective data. And as you can see, some of it's novel versus traditional, about 60% versus 50% in this Flu-Bu versus Cy-TBA or Bu. So there's traditional regimens are not good, and we did not pick it when we talked to you. And here is the analysis from Vikas Gupta in Toronto, Flu-Bu versus or Flu-Mel versus Cy-TBI, again 68 versus 48%. So you can tell us that we are right when we pick a newer conditioning regimen. Now, the reason why we think about Flu-Bu more than Flu-Mel, in my opinion, is this. So there has been two prospective studies, the EBMT Flu-Bu ATG regimen, which is Fresenius ATG or ATLG, and the MPD Research Consortium in the US, they did a prospective study with Flu-Mel with or without ATG. ATG is only in the unrelated donors in this study. So the EBMT group had 68% 5-year survival, and they had a bigger proportion of unrelated donors. And the US group, their survival for related donors graphs was 78% at 2 years, but unrelated donors' survival was pretty poor at 44%. So with Flu-Mel, what led to their failure was 26% primary graft failure. So I generally don't do Flu-Mel for these patients, although melphalan does, I agree, melphalan does give you the most rapid switch in chimerism, but I'm always try to do Flu-Bu for these patients. I actually sometimes do Flu-Bu 2, sometimes do Flu-Bu 3, sometimes do Flu-Bu 4. So basically risk adapt for the patient. And even in this Flu-Bu with ATG, 11% needed stem cell boost, 27% had some form of graft failure. So graft failure is the biggest problem in transplantation for this. What do we do if we give ruxolitinib and then do transplant? So here is spleen size reduction in a myelofibrosis patient, pre-therapy, after 2 months of therapy. So you can actually rapidly shrink the spleen in patients who get ruxolitinib. And that actually helps engraftment by a big deal. This is the spleen reduction in the COMFORT-2 study. I'm sure we all know about this. But problems with ruxolitinib is that disease persistence. It doesn't do anything to the disease. And these are the percent change in the JAK allele on patients on ruxolitinib. So no one gets 100% reduction even in the best responders. And some people actually progress without any response at all. And the majority of patients, the reduction is actually somewhere between 20% and 0%. So ruxolitinib does not impact the disease in a meaningful way. It has very limited anticlonal activity, in other words, and it can lead to worsening cytopenias, more transfusions, more donor sensitization, and you can get into trouble by using ruxolitinib for too long. Another problem, it is a very powerful T-cell suppressant, as you all know, because the JAK-STAT pathway is necessary for T-cell activation. That's why it works for GVHD, as Gorgon's talk suggested. And we have atypical infections. Actually, the incidence of reactivation of TB has been reported in at least 8 or 10 cases so far. Does not decrease the risk of leukemic transformation. The risk of leukemic transformation remains the same. And it is not tolerable for a lot of patients. The risk of discontinuation, most people end up discontinuing at around 3 years. And there is no convincing effect on bone marrow fibrosis. So it doesn't help you that way. So the problem with bone marrow fibrosis not going away is that primary non-engraftment is still a problem. But we don't know why that is, because there are other problems too. Splenomegaly is a problem. Transfusion dependency and getting sensitized to the donor is a problem. And then, is there a role of the cytokines? Because you have a highly activated inflammatory cytokine profile in patients with myelofibrosis. They are hypercatabolic. They have TNF-alpha, which is the single-most important negative regulator of stem cell expansion. That's high in those patients. But the biology of graft failure is all of these, not just myelofibrosis. And my point is that if you can have a patient that's responding to Jakafi, that's probably your best patient in which you can hope for engraftment. Also, there is some data, this is very interesting data, suggesting that there is a neuropathy of the hematopoietic stem cell niche, which is essential. It's actually, in this study, which is published in Nature, it was essential for the proliferative clone to survive. If you haven't read it, it's really worth reading. So the question is when to transplant. So I always recommend that we do it when there is clinical improvement or stable disease on JAK inhibition therapy. So to show clinical improvement, you have to give it at least 4 months. If you delay until the patient is intolerant or is worsening, you actually have several problems, such as increasing blast count, regrowing spleen, loss of response, all that. And once they have progressed to leukemic transformation, it's too late because the outcomes are really, really poor. So here is patients who have transformed to leukemia, and as you can see, only about 20% of them, actually very small percentage of them make it long-term out. So early versus delayed transplant in patients who have responded to JAK inhibitor therapy. This was again a study where people went around and put together cases. So we actually contributed about 30 cases to this, and Toronto contributed another 30 cases. We were the 2 biggest centers contributing out of almost 80 something patients in this. So if you are responding to JAK inhibitor therapy and at 4 months you have had a response, and that's group A, so you can see that those are the patients who do exceptionally well. Group E are the patients who actually went on and waited till it failed and went to leukemia. Group B, C, D are a group of everything else. Patients who could not tolerate JAK inhibition, people who had not been put on JAK inhibition, etc. So this is again retrospective data. There is problems with this, but this is the best data we have. So the timing question again, so younger patient, early disease, better prognostic score, likely to be okay without transplant, but those are the patients where you have the highest chance of success, but you could end up with the highest chance of reduced lifespan, and you could also impact the quality of life in a bad way. So this is one end of the spectrum. In the middle of the spectrum, when the patient is worsening, splenomegaly is getting worse, they get portal hypertension after they get splenomegaly, then they get iron overload because of the transfusions, and then they could get leukemic transformation. And finally, the older patient with really advanced, they have failed everything. So you have 3 different scores. And ideally, the patient you pick would be somewhere in this section. So ideally, we need a decision analysis study like Corey Cutler did many years ago and was repeated recently, where you do a survival time analysis with a modeling strategy, with Markov modeling or something, modeling the loss of potential life years with each strategy, and then use it, and the risk of delay is counteracted by the potential life lost by delaying versus the quality of life lost by doing a transplant and getting GVHD, etc. These are, price of early transplant can be bad. We really have to admit that too. So there is a risk model. The only risk model that exists is from EBMT study. Again, if you have no risk factors and you do the study, you do really well. If you have one risk factor, you still do poorly. If you have more than 3 risk factors, and these were the risk factors that were found. JAK2 wild type did poorly, age more than 57 did poorly, and constitutional symptoms did poorly. Then the question is, what do you do with JAK inhibition? We already said that graft failure may be helped by JAK inhibition. GVHD may be helped by JAK inhibition. I'm not going to go into that because Dr. Akpek in his talk mentioned that. And TRM might actually be reduced by JAK inhibition. We haven't proven it yet, but we're going to soon have a study that will show it from the CIBMTR, because better performance status immediately happens when responders to JAK inhibition, reduced cytokine levels, reduced spleen size, and all of these are helpful. Quality of life improvement. And so here is the other side of JAK inhibition. So this is the French study that many people in this audience know about. So the French had actually a planned allo prospective study on patients who were on JAK inhibitor ruxolitinib. So first patient, so they had 3 deaths and the study was closed immediately. So this was the first patient. They were on JAK inhibition. Spleen went down by 25%. Flu-Mel ATG transplant. And the patient got tumor lysis syndrome and got, when they, right after the Flu-Mel, and they never engrafted and they died in 5 months. So that was a pretty dramatic death. But they thought the tumor lysis syndrome was the reason for this. But the thing in this study, the important thing was JAK inhibition was stopped weeks before the conditioning. Second patient on Jakafi, spleen was stable. They did a splenectomy. They started Flu-Mel ATG, but they didn't get to Mel. One day of fludarabine and ATG, patient went into cardiogenic shock and patient was pulled out of the study. They didn't transplant him. Patient got stable disease and the patient's still alive. So this, yeah.
Don't have your transplant friend.
Right. So this is the patient, another patient, splenectomy because the spleen shrank 25% only, and cardiogenic shock. They got flu ATG, did not give the cells, progressive disease, and died in 7 months. So this actually was presented at ASH, and it killed post-Jakafi transplants for a while. So then us in Toronto decided to restart it, and we came up with a protocol where we came down on JAK inhibition stopping 24 hours before busulfan. That's our protocol now, and we've published on it. This is the paper that describes that. So we believe that if you stop JAK inhibition too early before allotransplant, you're going to get into the trouble that the French got in. We have actually had no flares in any of the patients so far. We have now transplanted 35 patients at our institution and almost 45 patients at Toronto. So here is a couple of patients from our paper. So this is a 64-year-old lady. Jakafi to transplant was 10 days in those patients, and that patient actually had pulmonary infiltrates and flare of splenomegaly. We actually rescheduled the transplant, retransplanted her, and transplanted her later, and she's alive 16 months later. Another patient with same thing, fever, hypoxic respiratory failure when the JAK inhibition was. This was again miscommunication between the patient and the instructions that the patient had. They were supposed to keep on Jakafi, they just did not renew it, and this patient also had their transplant rescheduled, but she died later. So if you look at the flare reaction here, sorry, Chris is right, it's just goes on. If JAK inhibition to transplant interval is more than 6 days, there was some form of flare in 30% of the patients. If it was less than 6 days, 9% of the patients had a flare. So we actually go all the way till 24 hours before. So and finally, you have to do an individualized decision making at these patients. We don't have data for, randomized data for many of these things. It's a complicated transplant. It is actually one of the most complicated transplants you will end up doing because of all the issues around it. So I'm going to just go on some of the key questions. So here is a patient of ours. So you can see her spleen and liver. This patient had secondary portal hypertension from extramedullary hematopoiesis in the liver. So she was kept on having varices in her stomach and variceal bleeding, esophageal and gastric varices. So there's nothing we could do. We ended up doing a shunt, a transhepatic intraportal shunt, and so did a transplant, and spleen has shrunk, liver has shrunk, portal hypertension has reduced. So then patient have kept on having portal encephalopathy because she was shunting portal blood into her systemic system. So we actually closed off the shunt by embolization, and the patient is fine, still alive and doing fine. So basically, portal decompression, transplant, and closure of the shunt. Second question, many hematologists, I'm sure nobody here, believe that fibrosis does not resolve after transplant. That is actually absolutely normal. It completely resolves, and here's a patient with intrasinusoidal hematopoiesis. Actually, Chris knows this patient. This patient was the dean of our hospital, and he was one of the first people we transplanted at our institution. So again, 3 months, 12 months, normal hematopoiesis, not even a trace of fibrosis. Here it's still fibrotic, so it's kind of patchy, but completely goes away. Not only does it resolve, the speed at which it resolves is prognostic. If patients get complete resolution in 3 months, those patients are almost never going to have a relapse. Here is a patient with osteosclerosis. So she was diagnosed by she went for knee pain and had an X-ray, and this was her knee. It looks like ivory from an elephant. She got transplanted, and this is what her knee was 1 year later. 2 years later, it's normal. It's same exposure of the X-ray. So you can actually reverse it completely. And if you do relapse, the relapse rates are very low nowadays in the Jakafi era for whatever reason. But if you do relapse, a second transplant or DLI can reverse this. So that is another issue. And then finally, some people ask the question, do you do Jakafi maintenance after transplant? So if you have donor chimerism, does it make any sense to do Jakafi maintenance? Because the target is no longer there. So if you don't have donor chimerism, obviously there is a clone there and you could do Jakafi maintenance. But remember, Jakafi maintenance means you are actually reducing the immune effect from graft versus leukemia. So I don't recommend it as a thing. So I think this is this talk. So questions?
Thank you very much. Excellent speech, Dr. Hari. Any comment or questions? Yes, please.
So we do what you do because I phone you and ask you what you do, and then I do it. But could you comment a little bit about the toxicity? I mean, when we looked at it, there's increased VOD risk because of something's wrong with the liver.
Right.
But I don't know, could you talk about what that is and how often you see liver troubles post in these patients?
So the liver, so that's a very legitimate concern because of the risk of extramedullary hematopoiesis. In fact, you really don't know who has extramedullary hematopoiesis in this situation. So what we tend to do is to put everybody on ursodiol for months before we end up doing it, and reduce the busulfan dose to only 3 days if we end up not, and we always check busulfan levels even in those patients. We have luckily never had a VOD so far, but FluBu2, FluBu3 are highly unlikely to get VOD. FluBu4 you would end up getting VOD, and that we reserve for people who we know have definitely. And the other thing we end up doing is for patients who have more than 22 centimeter spleens, we always radiate the spleen. It doesn't need to be full-blown radiation, because if you do full-blown radiation, some of these people you actually will hit the kidney. So we just radiate 10 to 30 gray, 10 gray for smaller spleens, 30 gray for bigger spleens, just part of the spleens, partial splenic radiation.
So when you mean 22 centimeter, is the ultrasound length?
Yeah, long axis, 22 centimeters. That's so there is no data for doing this. So when we publish, we have actually a presentation at ASCO this year about what we do for these patients, but we have not published it. The data comes from previous Italian data from Dr. Bacigalupo, where his non-engraftment was all for people who had more than 22 centimeter spleen. So we just picked that 22 centimeter and decided to radiate those patients.
Sinem?
So I was going to ask whether you were going to splenectomize your patient if he failed after JAK2 inhibitor. So I think you answered.
Right.
And